So Rebecca and I are going to actually talk to you a little bit about some of the work that we got committed to prior to her leaving University of Toronto when she was here, and we've been learning together about this area in relationship building through co-learning and possibly the impacts that we might actually discover related to feedback and coaching. So the first thing we just wanted to really bring attention to is the fact that there is increasingly more and more literature in the area of feedback and coaching, even within medical education. But I think what we need to acknowledge and just be very explicit about is the fact that there's still a lot of confusion and a lot of unknowns. And in fact, several times this afternoon in the other forum with a little bit of a smaller group, I heard people say, you know, the more I think about this and the more I read, and certainly this is from my perspective, the more questions I actually have, and that, you know, there's a lot of work to be done to try and understand how this fits within our context of medical education, and if it fits, or what components of coaching fit in the context of medical education. So, and the only other thing I just want to sort of call out is the fact that the literature right now doesn't have widely accepted common definitions, so we do need to be careful to recognize, you know, what we're actually talking about and if we're talking about the same things despite using different words. I'm not sure it matters the words that we actually use, although Shifra, you'll probably disagree with me since your focus is words, right? But we need to be clear about what we're talking about. I do think, though, that since we're talking about this in the context of this shift towards competency-based education, that, you know, it gives us just reason to pause and maybe even look backwards to really ask ourselves, what is the purpose of postgraduate medical education? And certainly in the context of CBME, you know, the focus is more towards individual, tailored professional development of competence. And there are lots of tensions, one of which I think I've been actually thinking a lot about, and that's, you know, since actually medical education came into the university sector after Flexner's report in 1910 and moved away from more of a one-to-one apprenticeship model. How does the tension between how much is education and how much is service play into how we actually coach residents for improvement when, and now I can't remember who of the panel said, but when we expect our medical students that become residents the next day to all of a sudden be able to do something and don't come actually with that lens of, I'm here actually because I want to get better and learn more. There's the threshold there. With, however, this shift towards CBME, we're just going to, in the next few slides, highlight a few things that we've been thinking about while we're doing this work on relationship building through co-learning that really represent opportunities for us to really think hard about, because at the very least, it's opportunities to look at what we're doing, what we value in terms of medical education, and so then how that actually, imposes on or feeds into our implementation of that. So the first of these sort of shifts might be, and we've heard a little bit about this already, that we need to do some very critical thinking about this idea of assessment and a more summative assessment that we've had in the past, for example, at the end of a month rotation or a 3-month rotation or whatever length of rotation a resident has an ITER filled out. So it's not, of course, the ultimate summative, but it's still summative in nature in terms of its assessment of their learning at that point in time. as opposed to if one would take on more of a thinking of clinical teachers being learning coaches, where they're actually giving coaching and feedback on a regular day-to-day basis, which would lower the stakes of any one of those particular coaching conversations. It becomes embedded in the normal practice of medical education and shifts away from that summative sort of perspective where the stakes are higher to observations to inform learning for residents. So that shift from a clinical teacher as an assessor to the clinical teacher in the clinical environment as a learning coach, and therefore the shift away from assessment of what is known by that learner to the observation for potential improvement in coaching. The second sort of shift that's certainly being talked about in the literature, and I'm not going to go over this in depth since Shubha just actually did that for us, but that encouragement that we maybe have to shift away from fixed mindsets, learners as well as clinical teachers, and towards a growth mindset. Encouraging that mindset would certainly encourage reflective practice and also potentially more self-regulated learning. And I would just suggest that in the long term, that's actually what we need as competent practitioners in our practice. We need to continue that from the perspective of self-regulated continuing professional development. And just pointing out that in terms of, the literature, in 2001, there was 2 publications with respect to mindsets, fixed and growth mindsets. And by the time we roll around to 2018, there was 39 publications. So it's certainly an area that is increasing in terms of what's being thought about in a academic way. The third shift is actually where the crux of some of our work is, and that's the shift, and what you've already heard multiple times today, which relates to this idea of the importance of relationship in terms of giving feedback and coaching. And how a relationship develops. There's lots of questions around how much time does that actually take, and for every coachable moment, does it really necessitate a long-term relationship, or can we actually learn things, maybe not from ballet, but from other domains which use coaching to actually help us in terms of that coaching in the moment? How much of it relates to the explicitness of people assuring that both sides of the dyad, the receiver and the giver of coaching and feedback, are aware of the roles and the expectations. So time is one thing, and certainly in the literature, trust is something related to relationship that is also important, but also undefined in terms of how long does it actually take, and is it trust in the people or is it trust in the process? But certainly there is actually papers being published, like this one that was published by Summer Tilio out in Vancouver and her colleagues, that actually describe the necessity and the importance from a credibility perspective of having an educational alliance. And she draws the parallel to a therapeutic alliance. And I think a lot of times if we think about the relationship that we try to foster between our patients, that can also parallel with a relationship that we need to develop with our learners in order for them to be able to incorporate and utilize any coaching or feedback that they're providing. There is certainly others that have published as well. So Joan Sargent and a number in her group have talked about the importance in their R2C2 model of coaching, recognizing that that model was first conceptualized within the continuing professional development context. But there is some transferability, certainly, and they've written on that. But the first step is actually building relationship and rapport to that model, after which reaction, content, and coaching comes. This is just one of the tables that they actually outline the steps, but relationship and trust continually come up in that model. And then lastly, in the work that I've been doing with multiple other people in the room around the coaching model for the Royal College, where we have coaching in the moment and coaching over time, but certainly the initial part of that model and process is about building educational rapport and actually setting expectations, which then thereafter follows the observation that needs to happen, the conversation or dialogue or coaching or feedback dialogue, and then documentation. So those are just three sort of examples of some of the work that's being done currently and also been published in terms of the importance of relationship. And as we shift towards this emphasis on relationship, thinking that it would actually enhance the effectiveness or utilization of feedback and coaching, I think the recent article that was published by, I can't remember his first name, Ajawai. You remember? Rolla, right. And Glenn Greger, just in this year, 2019, medical education, they've described a really new take on feedback, where feedback, as Shubha mentioned earlier, is a co-constructed process, where that sort of co-construction and collaborative nature of it with shared problem space or shared space to problem solve emphasizes the importance of mutuality in terms of goals and roles, and also engagement in the process of both sides, not only the giver of coaching and feedback, but also the receiver, which Shubha has also emphasized in her model that she just showed you. And there's certainly also some emphasis in terms of this educational alliance, where it's recognized in the literature now on multiple occasions that this mutual understanding of the goals and roles and how to actually attain them is important in terms of the ultimate utilization of any feedback and coaching, and that lending it to the credibility that was spoken of earlier, that there needs to be that at least perception of, from the learner's perspective, of commitment to the learner or commitment to their learning, so that they feel that the faculty or the clinical teachers are really engaged in that partnership. So the recipient's perception of that relationship is a real key determinant in whether or not that alliance has success. The last thing I'll just say about the idea of the importance of relationship with, when we're considering feedback and coaching, is just that it's really complex, because we are human and because it really is a social interaction, and sometimes our words don't mean what they really, what the words really are saying. We have to have this layer of interpretation. But there's other factors that come to play as well, and that's that each one of us brings a past, and how we've actually, what you're experiencing right in the moment is 90% based on what you've experienced in the past and only 10% of what is actually happening in the moment. We each bring our own beliefs, we bring our own attitudes. And so, you know, these interactions are influenced by the individual people, but probably also whether or not there is a relationship or whether it's been a focus of building that relationship. And then, as you've heard multiple times already today, the culture of the domain that we're actually in and the context of the environment that we're practicing in. So the fact that actually every day is game day in medicine has a role to play in how we think about how coaching can be useful, or how it might have to be different than in a sporting or an arts context. And so with that, I'll just stop and turn it over to my co-partner.
Okay, so just continuing on that. So I think Denyse very nicely set the stage, just emphasizing how medical education has been changing in the last couple of years and how we're seeing more of a focus on the relationship as being crucial to the effectiveness of feedback and coaching. And as part of that, I'd just like to introduce a concept called co-learning. We ran across this concept when we were looking for a way to increase capacity within both residents and teachers at U of T for giving and receiving feedback and medical education coaching a couple years ago. Although it's a new concept, it was coined by Dr. Brian Wong here at Sunnybrook. And it describes a process by which faculty and learners faculty and residents learn a content together. So they're physically in the same space, they learn from each other, they learn together new content, and they share perspectives that contribute to each other's learning. And given the shift in medical education towards relationships and the importance of relationships in feedback and coaching, we thought this would be a really good paradigm upon which to build our teaching about feedback and coaching towards our faculty and our trainees. So Brian Wong and colleagues at Sunnybrook used this to teach about quality improvement. They had novice faculty and expert faculty, along with residents, learning about quality improvement, creating quality improvement projects, and being mentored about quality improvement projects together and at the same time, and found some good success with that. So essentially, we're looking to shift this to a collaborative process away from a unilateral or unidirectional process. So we used a co-learning approach to design multiple interventions to teach residents and faculty about feedback in coaching. So we had a number of elements to our intervention, and those included a workshop, a grant program for seed funding for the development of local initiatives, a conference, as well as the design of a resource bank. And all of these different elements had in common that they were co-taught, so they were taught by a faculty as well as a resident, and they were co-attended by residents and faculty. So for example, for the workshop, we delivered this workshop to departments, and residents and faculty from one department attended. The workshops were led by a faculty and a resident pair. And the idea was really to get people talking together about the process of feedback and coaching. And as an example for the grant program, the seed funding was eligible to local resident and faculty pairs who had ideas for improving feedback and coaching at their local level. But one of the application criteria was that the applicants consist of a resident and a faculty together in order to be eligible. And so our idea was that people would be learning together. They would learn from each other's experience. And our goals were that the faculty and the residents would be creating a shared mental model about what the process of feedback in coaching looked like, what the challenges were for both sides together. We were hoping to kickstart some relationships and really build a joint sense of ownership over the process of feedback and coaching. So building a sense of developing an action plan for moving someone's progress forward or moving someone's performance forward is something that we do together. After the deployment of our interventions, which started in 2016, we set about evaluating what the impact of co-learning was, and was this an integral feature to the success of any of these programs. We have some just preliminary findings. So starting off, we've conducted some focus groups, and we've been able to identify that co-learning was really seen as integral to the success of the programs from the point of view of the participants, and also that the co-development of the interventions was also seen as integral, so development of the interventions by the faculty and the resident. We also found that a community of practice, which included both faculty and resident medical education leaders, was created. And some of the quotes here from our survey results do indicate that the relationship was a key feature. That was a takeaway point for most of the people who attended either our workshops or our grant program, etc. We're continuing with our evaluation with some semi-structured interviews, and we hope to take a look at the impact of co-learning on the relationship between the residents and the faculty, on potentially their ability to engage in a growth mindset. You know, is that easier when both the faculty and the resident have attended jointly a workshop and have a good idea of what this process looks like and how difficult it is from both sides? And we also want to take a look at, does this create a shared mental model where both sides have a good understanding of what the process entails, and how helpful is that? So from Denyse and I's talk, we would like you to take away these major messages. First of all, we have some major shifts in medical education, which we have all heard lots about today. So from assessment of learning to assessment for learning, we are shifting towards being learning coaches rather than assessors. From a fixed mindset towards a growth mindset, one that embraces failure in whatever form we can accept in medical education, and towards an emphasis on the relationship in feedback and coaching interactions in medical education. From our perspective, we are investigating co-learning as a useful tool to help us shift our approach towards feedback and coaching. We're wondering whether it helps to emphasize the relationship, whether it creates a shared mental model around the process of feedback and coaching, and whether it enhances the success of interventions to increase capacity for feedback and coaching by creating a joint sense of ownership over the process of coaching and feedback.